सब जॉइंट। अमित सर, गौरंग सर को होस्ट बना दो ना, क्योंकि सर मैं ट्रेन पकड़ने वाला, मैं
ओके ओके,
नेटवर्क चला
डन डन
जाएगा।
डन।
ओके।
ठीक है, मैं सर को होस्ट बनाता हूँ। ओके।
और मेरे को को होस्ट बना देना।
हाँ हाँ ठीक है, तो आपको को होस्ट बना दिया। और किसी को बनाना है को होस्ट अपार्ट फ्रॉम
नहीं,
यू?
सर को होस्ट बना दो, बना देंगे फिर।
ठीक है, डन डन डन।
ओके, थैंक यू सर।
ज्यादा नहीं करना है। पानी दे देना ना। क्या जी? आ जाना।
गुड इवनिंग वीरेंद्र।
सर गुड इवनिंग।
बड़े स्मार्ट लग रहे
सर आज आपको कोई मिला नहीं है। इट्स बीइंग
अरे यार,
रिकॉर्डेड।
तारीफ करने में क्या दिक्कत है?
Good evening, sir.
जस्ट
After a long time, actually.
या हिरेन गुड इवनिंग।
Good evening, sir. Good to see
Hiren,
you,
do you
sir.
agree with me or
This
not?
is absolutely, absolutely, sir.
Like,
We were missing him actually, and today it's
Ex-
his topic.
No, actually for Gyanendra, na, we are waiting for to find a, you know, opportunity to calling.
Really, sir.
सर
It's
नहीं
a
सर, I will
really, great thing to listen to him, his comments and his the way of discussing and teaching. So we are
Really
very
good for the
happy. And
students.
sir
yeah,
honored
Pankaj,
honored by these words, sir. But I will make it a point to attend subsequent meetings.
yeah,
Sir, unfortunately, I am a very lazy person. Need lot of pushing from Pankaj to.
acha. So today, na, I have asked our the thing, nuclear
Nuclear
medicine
medicine. Yes.
Yes,
person to join during the discussion of
The
renal
renal scan.
scan, you know. So I will call him when we go for investigation.
sir.
So if once I just see Gite sir has joined. Who is answering today?
Good evening, sir. Myself, Anand, sir. Anand from Jaslo.
Anand.
Yes, sir.
Who else? Who else is answering today?
Hello.
Yeah.
Dr. Kavan and Dr. Anand, sir.
Anand and Kavan. Two of them are answering, correct?
Yes, sir.
Okay. Fine. Dr. Gite will join soon, I think, because he is traveling. I think we can start. Yanendra,
Yes,
can
sir,
we
I'm
start?
ready. Yes, sure,
Right,
sir.
right. Fine. Okay. Bridget, you can start the case.
Hello. Yes. Am I audible, sir?
Yes.
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 So, a 48-year-old female present with a complaint of pain over right flank since 1 month.
Anand, can you elaborate the history?
Yes, a 48-year female presented with a pain in the right flank. I would like to illustrate the nature of the pain, whether it is insidious or means onset duration and progression of the pain, sir. Then I would like to illustrate the associated symptoms, sir. There is associated with fever, uh, any signs of fever, burning micturition, uh, and any non-urological causes of right flank pain, sir, whether it's any colonic or uh, gallbladder.
Hello.
Hello, sir.
Kavan, you want to add anything?
Sir, to begin with in the history, these findings will be enough. The nature and character of the pain and any associated other complaints, such as any history of fever or any past history we would like to elicit.
Okay. Bridget, just tell them the full history.
So, patient was asymptomatic before 1 month, and she developed pain around 1 month, which was dull, aching in nature. Sudden onset, radiating from loin to groin, gradually progressed and increased since last 15 days. She also had associated nausea and vomiting, no any specific aggravating factors, and it was relieved on taking analgesics. So there was no history of any previous operative intervention, no any lithuria, no hematuria, no facial puffiness, no any excessive breathlessness, no jaundice, no headache, no backache, no bleeding disorders, and patient was not on any blood transfusion or anticoagulant therapies.
Okay, so Anand, this
Yes,
is a
sir.
history. Now, what extra points you want to know? When the patient
Yes,
is
sir. These
giving you
were
so much of
enough.
history, you want to ask anything extra?
No, sir. I would like to proceed.
Kavan, you want to ask anything?
Sir, I want to ask the patient regarding any relieving factors. because the patient gives the history that it is intermittent in nature. So if there are any associated relieving factors that we would like to ask.
You don't want to know anything about menstrual history,
Yes,
this
yes,
thing,
sir. Yes, sir.
and how many deliveries, that is obstetric
Yes, sir.
history,
Obstetric
nothing
histories.
regarding that.
Yes, sir. I would like to ask.
And during the obstetric history, whether the ultrasonography was done, it was suggestive of any, whether abdominal ultrasonography was done that time, and whether that time kidneys were normal or whatever it was, there was a stone or anything was detected. Nothing. You don't want to know anything about this.
Sir, patient already has no past history of lithuria. So I think that information is there.
Jnanendra ji, now please
Yeah.
take over.
Now, a very funny question to Anand and Kavan. The patient says कि right-sided loin pain है. You will be doing an ultrasound? Yes or no?
Yes, sir.
Then why do
Yes,
you
sir.
want to ask all this history?
Sir, for any case, we need to know the current and the past history of the patient. It gives us a clinical idea. It also gives us the thought while doing the sonography ourselves, or when we order a ultrasound, that what findings we need to focus on. So which area to focus on, it gives us that help.
I think, Kavan, you belong to Nadia, so you are doing your ultrasounds. Most of us send it to a sonologist. So why do you want to spend so much of time? Ultrasound तो करना ही है. Sonologist is going to see everything. So why do you want to ask this much history?
Sir, before ordering an
Sir,
ultrasound,
the history will give some clues, sir, regarding which
Regarding what?
pathology we are dealing. Underlying pathology somewhat, sir. If the pain is suggestive of this loin to groin radiation, so it could be upper ureteric stones.
Yeah, you are very close to the answer. I will give you a reference to it. I think in 2000 or 2002, somewhere in this period, there was an issue of British Journal of Urology on uroradiology, where they said that if clinically you suspect that the pain is on account of a renal cause, you are likely to pick up a pathology more than 50 to 70% of the times. In contrast, if clinically you don't feel that the pain is due to a renal cause and your investigation like ultrasound show mild hydronephrosis, there is no point in going further because the chances of you picking up a renal pathology would be less than 5%. And this is where the importance of a clinical history comes. Because suppose somebody is having a small stone with mild hydronephrosis. If the clinical history is suggestive, then probably you would, following an ultrasound, order further investigation. But if clinically you don't feel and there is just mild fullness of the pelvic elevation system is mentioned, your chances of getting something positive on investigations would be very, very less. Yeah. So can we go further?
Yeah, British, go ahead.
Yeah, she was non-hypertensive, no diabetes, no any previous comorbidities. Her obstetric history was normal, only one child with normal vaginal delivery before 15 years. And menstrual history was regular, no normal menstrual cycles. Diet was mixed diet, bowel habits were regular and normal, and blood was sleep was also normal.
Fine. So,
Yeah.
Anand, now next what?
Yes, sir.
You want to ask anything extra or you want to go ahead?
Yes, sir, I would like to proceed, sir. General
Okay,
examination.
so, okay. Bridget,
General examination was also grossly normal. Only there was mild right-sided renal angle fullness which was visible. Clinically, there was no any obvious palpable lump. Percussion and palpation was also normal, sir. no any raised temperature.
Yes, Kavan, you are interested in any extra university, I mean, this thing, findings or anything you want to know, or this is enough?
Sir, on examination, these findings are enough, sir.
Okay, so Kavan, now next what you want to do?
Yeah. One question to
Well, yes.
Anand, anybody can answer. A very basic question. Suppose you feel a lump over there in the lumbar region. How will you differentiate it from a renal lump from a liver lump? 1, 2, 3, 4, 5. You must have answered it hundreds of times from your MBBS days, but just for the sake of repetition.
So on palpation, the renal lump would be most palatable, and the position is also in the little down, sir. For the liver, sir, it is in continuity, means slightly upwards, sir. And
Sir, in case of a liver lump, it will be moving with the respiration because of the diaphragmatic attachments, as
So
well as in case of a liver
renal
lump,
lump also moves with
Kidney
respiration.
also moves.
it is significantly more in liver lumps.
No,
Also,
it is there in both the lumps.
sir, we will not be able to get below the costal margin in case of a liver lump, while renal lump we can get below the costal margin.
Right. See, the usual answers are moves with respiration.
yes, sir.
Fingers can be insinuated beneath the costal margin in a renal lump. Bimanually palpable, ballotable, and on percussion there is an anterior band of colonic resonance. ये 1, 2, 3, 4, 5 बोलना ही चाहिए. I don't think any examiner at MCH or DNB level will be asking it, but somebody asks you and you are not able to answer it. It's a big letdown. So that was the reason for asking this. Another basic question quickly, then we move on to the further thing. Classically, the ballotment is felt in a fetus with a gravid uterus. Why is the kidney ballotable?
So the principle behind the ballotability is the presence of a long pedicle of an organ. So,
In a fetus, which is the long pedicle?
sir, gravid uterus moves freely inside the abdomen. So that is the principle behind it. The renal hilum, the renal artery vein, and it is longer. So the kidney is ballotable because of that, sir.
So you mean to say a left kidney will be more ballotable than the right kidney because the renal vein and artery are longer on the left side as compared to the right side?
Sir, both the pedicles are long enough to elucidate.
Sometimes, if you have seen a lot of radical nephrectomies, the renal vein is hardly a centimeter or so, to say 1.5 centimeter. Pankaj sir.
Haji.
Yes, sir. Your comments.
Yeah, what you're saying is right. Pedicle is really not the main reason.
See, Kavan, the basic reason of ballotment is that there is a structure which is surrounded by fluid. And in the case of kidney, it is surrounded by perinephric fat, which is somewhat in a much, it is not solid, it is not exactly
low density structure.
Low density, which helps in eliciting this ballotment. So that is the answer for this.
So basically you need space for something to move.
Yes. Yeah. So after these few basic questions, I think we move ahead now.
Gaurang sir, I think Dr. Anil Takwani has also joined. Maybe we can make him a co-host.
Yeah, Dr. Takwani. Welcome, Dr. Takwani.
Good evening, sir.
Good evening, good evening.
Let me listen properly this.
Yeah,
I am also learning
no
and
problem.
revising
But
my
in between
knowledge.
also, you can also ask the question. Okay.
Right.
Okay,
Thank you.
Bridget,
Thank you very much.
Bridget, go ahead.
So we moved with urine routine examination and urine culture examination. So this is urine routine report.
Kavan and Anand, you look at
Yes,
this
sir.
urine report, and the urine report has come to you, and will you advise the same specimen to be sent for culture, or you will take a fresh specimen?
So I will advise fresh specimens, sir.
So you will ask the patient to give sample 2 times.
What is the problem in this sample?
Yeah.
Lots of epithelial cells are high.
So what does that mean?
Contamination.
Contamination, or properly बताइए ना, contamination of what, from what?
Skin.
So Anand and Kavan, basically the sir is asking you very simple question. How will you collect for the culture and sensitivity?
Sir, one thing is the urine routine sample is not taken in a sterile container. So the urine culture and sensitivity goes into a sterile container. Another thing is when patient is told to collect a urine culture report, we tell them that you catch a midstream sample to prevent that contamination. Also, to in case of a female patient, because of the sitting posture, we tell them that you keep your legs wide so that the labial and perineal skin doesn't get the urine which comes into the container to prevent the contamination.
So there are 3 important words that you need to say. You have mentioned one word out of that. That was a midstream sample. So the 3 important words are: one is it should be a fresh sample, a clean catch sample, and a midstream sample.
And let me tell you, this particular sample must have been collected in a sterile container, because usually those labs which test nitrite, they give a sterile container.
What is the significance of nitrite?
Yeah.
Sir, presence of bacteria, sir. Peroxidase for RBCs.
Come again?
Nitrite is for bacteria, sir, and peroxidase is for RBCs.
And what is leukocyte esterase is for? So suppose you do a dipstick test, and in one patient nitrite is positive, and in one patient leukocyte esterase is positive. What will be your next step?
Sir, leukocyte esterase test mainly suggests that there are WBCs, white blood cells, present in are specific for some bacteria, which is the byproduct of the bacterial metabolism, and they usually test the gram-negative bacteria.
So the bacteria convert the nitrates into nitrites. So if there is nitrites, only then means that's an indirect sign that you should send the sample for culture. So in this patient with nitrite negative, the possibility of culture coming positive will be very, very low. And if it is leukocyte esterase positive, that only means pyuria, or say WBCs in urine. And in such patients, either you should collect a better sample or look for some source of inflammation.
Yeah, so this is the culture report. Yeah. We move ahead.
So
What
basically,
next?
this blood panel is normal, creatinine is normal. So what do you need next?
Sir, I am suspecting a cause of pain on the right side. So I would like to get a ultrasound of the KUB region.
Ultrasound.
The patient didn't bring the ultrasound film, so we had the report. Report showed there were multiple gallbladder stones, and the kidney on both the sides are normal. The right side kidney, renal outlines are smooth. The renal sinus on the right side is dilated with the presence of large 65 cross 60 cyst in the lower pole of the right kidney, probably compressing the right upper ureter. There was a 7 calculus in the lower pole of the left kidney. Uterus was normal in size with multiple fibroids in anterior wall intramural. And impression was the multiple small gallstones, large cyst in the right kidney, probably compressing the right upper ureter, causing grade 1 hydronephrosis. Small non-obstructive calculus in the left kidney, and multiple small uterine fibroids.
Okay. So what next?
So the ultrasound suggests a large cyst approximately measuring 65 by 60 mm. So I would like to elicit the cyst further, sir. So I will go to the contrast CT, sir. Patient creatinine normal.
Can I ask any one of you differential diagnosis at this juncture? What are the diagnoses in your mind?
So depending on the ultrasound, sir, the renal cystic disease, sir. Then the stone is the second one. Then PUJO obstruction in third. Fourth
Why
is
PUJ obstruction?
so there's a
Initially,
dilated
before sonography, it's okay, but after the sonography, why you're
Yes, yes,
still
sir, sir.
suspecting?
Down the line, sir.
So after seeing the ultrasound, the cause may be the large cyst which is compressing the upper ureter as mentioned in the report. Another thing that can be that it can be a missed upper ureteric small calculi which is causing the pain. So these two can be the diagnosis. But to further clarify the thing, we should go ahead with the CT scan.
You are seeing a day in, day out cyst, a simple cyst, large. Does it cause very routinely these obstructive symptoms and the changes in the sonography?
No, sir. Most
What
of them
kind
are
of what kind of a
most of
cyst?
them are
Then what kind of a cyst you are suspecting?
It can be a parapelvic cyst,
parapelvic cyst.
which
Okay.
lies just below the renal pelvis, and it can cause the compression of the upper ureter. But it is a rare.
Back to the Dr. Gyanendra.
Yeah, I think we go ahead with their CT.
You just slowly show them all the different fields, and then they can ask the question.
Yes, sir.
Looking to CT scan, are you agree with sonography findings? Because unfortunately, don't have a sonography plate.
After seeing the CT report in the contrast film, we can see that it is not a hypoechoic area which doesn't correlate with the finding of a renal cyst. It seems like a dilated renal pelvis only.
Back to Gyanendra.
Yeah.
Gyanendra, you
So-
need to ask so many things on sonography, I think.
No, but the sonography report was such that what am I supposed to ask? Nothing. sonography report mentioned a cyst, and they were perfectly justified in asking for a CT urography.
Perfect,
And
perfect.
so perfectly fine. So when
And
you
that's why there is an importance of having a plates.
yes.
So you yourself can also make a comment.
Mhm. So what is your interpretation of these CT films?
Sir, it seems like a dilated renal pelvis with the dilatation of few pelvis on the right side. And the ureter seems normal. There is no evidence of any hydroureter. Also, there is an abrupt cutoff at the pelviuretic junction. Both the kidneys are function wise, they look normal. It is good excreting kidney, and also it is draining well. While the drainage right is a bit delayed, but still it is draining.
How
There's
did
a
you
non-obstructive
come to
flow.
all these conclusions that it's a delayed drainage?
Sir, we can see that lower ureter is well opacified, and in the second plate we can see that the contrast is not very dense in the pelvis.
No, that's fair. I agree that contrast is seen in the ureter. But to call it a delayed drainage, you will need to take delayed images.
Yes.
On a single time image, how can you comment on a delayed drainage?
It is excreting, basically it is excreting.
Okay. Anything else? Can you show the previous image?
What sir is trying to say is you have to be very careful with your words. What you're talking in the exam.
Anything else we can see here?
You have not commented about parenchymal thickness at all.
Yes, sir, it is
Yes,
both the kidneys
grossly normal.
thickness. The kidneys look normal in size also, and the contour is regular.
Yes.
No, I
Let's
think
say
on the
normal.
right side, left kidney parenchyma appears to be uniformly thick. But right at the lower pole is little bit thinner, I think.
And you should also mention about the stone in the left kidney.
Stone in this side.
Yes, sir.
Okay.
No,
Now,
no.
in the patient where CT is done or contrast CT is done for PUJ, now you have diagnosed PUJ. Anything else you will be interested in seeing?
Any aberrant vessels?
Which vessels?
Any aberrant vessels?
Better to call it crossing vessels.
Or
Yes.
accessory apparent.
Okay. Can you see any
Lower
crossing
pelvis.
vessel here?
For that, we need arterial angiographic phase.
Not necessarily. If you look at the middle image in the second row, there is an impression of a vessel there.
Yeah.
Okay. So, but this is something try to keep a watch for, especially if your diagnosis is P junction obstruction. So let's summarize now. So we can say that left kidney is normal. There is a small stone in the left lower calyx. Right is moderate hydronephrosis, irregular patchy reduction in the cortex, and dilated balloon renal pelvis, probably a crossing vessel suggestive of PUJO.
Sir, I would agree with everything except moderate hydronephrosis.
क्यों भाई?
सर उतने कैलाइसिस डायलेटेड नहीं है.
ओके ठीक है. जरा पीछे जाइए तो एक बार फिर देख लें कैलिक्स. नेक्स्ट इमेज. ठीक है साहब, ग्रांटेड.
थैंक यू.
The report was suggestive of right hydronephrosis with significant dilatation of extra renal morphology. Right renal pelvis and mild dilatation of right renal calycis. AP diameter, prominent extrarenal morphology, right renal pelvis measuring 4.5 centimeters, and right ureter is not dilated. Non-obstructive calculus, no obstructive calculus seen. Right renal contrast excision is maintained, mild thickening and enhancing of the walls of the right renal pelvis, and right ureter is suggestive of right pilates and ureteritis. No evidence of pyelonephritis. Right kidney shows normal enhancement in corticomedullary and nephrogram phases. And there is a 5 mm non-obstructive calculus in left side with average HU value of 450 to 550 in lower anterior calyx.
Now, Kavan, looking at these CT findings, I will give you a chance to ask one more history to the patient. Which history would you be interested in asking?
Sir, I would like to ask that with the during the episode of pain, if after passing the urine, pain reduces or not,
Very
because
good.
typically details crisis is not associated with crossing vessels, and here the cause is crossing vessel, seems like that. So that is the history point.
Very good. So, what next?
Sir, I would like to go with EC scan, sir, for the functional assessment.
फंक्शन तो मिल गया ना यार सीटी पे.
Still, sir, baseline differential function is.
So you have any doubt that this is PUJ obstruction, or you do not have any doubt?
No, sir, I don't have it.
So you are 100% sure that the
Why
pain is
why
on
not
account-
it can be a dilated congenital pelvis, non-obstructing dilated congenital
Exactly.
pelvis.
So are you sure that the pain is only on account of this PUJ obstruction and it cannot be anything else?
Sir, we need a functional radionucleotide scan, because CT, even if a contrast CT, is an anatomical investigation, not a functional investigation to say. So we need the proper assessment and documentation of the obstruction, as well as to document the split function of that kidney, because a patient is 48-year-old. The entity is since childhood maybe. So we need to document the function also, split function.
Also for further follow-up.
Okay. Right. Definitely with such a dilated pelvis, we would like to assess it by a renogram, because it could be a purely extrarenal pelvis, or it could be an obstruction caused by a vessel which is crossing that particular PUJ and causing intermittent PUJ obstruction. So fair enough that a diuretic renogram would be needed in these cases to evaluate what is the differential function. Secondly, how good is the drainage of that kidney, renal pelvis as well as the kidney. Right. So when the patient is going for a renogram, what are the instructions you will give to the patient?
The patient should be well hydrated, sir. Then hydration.
Gyanendra, we have got Dr. Parag, who is a nuclear medicine,
Wow, very nice, sir.
with us. Parag, you are there?
Yes, sir, I'm here.
Yeah. So you can, along with them, you can also ask the questions and teach them. Okay,
Sure, sir.
so you can
Sure.
start from the beginning about the nuclear scan, what you would like to ask the student.
Okay, sure, sir. So basically, renogram, you do a dynamic renogram for assessing function and drainage. Would anybody like to volunteer to answer when do you choose a DTPA versus an AC or a Mark III?
Sir, basically, the DTPA is a glomerular extract, while MAC3 and EC are tubular extract. In this case, we want to diagnose basically PUJ obstruction, and we want to confirm it. So, and the kidney, the function and everything is normal. So we would like to go ahead with a tubular extract, because adding GFR to that report will not give us any further advantage, but the obstruction will be better delineated in a tubular extract scan. And because of the easier availability and the cost benefits of the EC scan, we would like to order an EC scan in this case, sir.
Okay. Any specific indications where you could do only an EC and not a DTPA?
Sir, because it is a glomerular extract in infants and early childhood, when the glomeruli are not very developed, in that case, and in when the creatinine is more than 2, then the glomeruli will not function properly to excrete the DTPA
Right.
agent in these cases,
Right.
sir.
Right. So the extraction fraction of EC by the kidney is higher than that of the DTPA. So when you have impaired renal function, specifically the serum creatinine about 2.5, that is when you prefer an EC over a DTPA. You also prefer EC over a DTPA in pediatric population, especially which are more than 3 months of age. After 3 months of age, the DTPA works just as well, but before 3 months of age, the renal maturity is still not there. In those conditions, you prefer an EC over a DTPA. In this particular condition, where the elderly gentleman is about 48 years old, if the baseline renal function is good, EC as well as DTPA both work just as fine. Right? So my
Yes,
next
sir.
question is, what are these? Why do you need a DTPA renogram or an EC renogram? Why not a sonography, a CT IDU, or even an IVP?
So the radiation risk of these DTP or EC scan is lesser. These are non-ionic, and even though in impaired renal function, this scan can be done. These are the added
Well,
DTPA.
partly true, yes, but primary thing is you can quantify renal function. When you look for a renogram or any scan that basically tells you about obstruction and you are choosing to decide based on the scan whether to intervene in this patient or not, you want to know how much is the absolute differential function, because a fall of differential function of less than 40% is one of the signs that you need to intervene and operate. So you need to know absolute differential function, which can be quantified only on renograms. So IVU or even CT IVU will not be able to tell you the absolute differential function. Point number 2, it can differentiate a passive dilated pelvis from a truly obstructed system, which eventually is going to cause a fall in absolute function of the kidney. And third is you need it as a baseline for a pre-operative renogram for you to compare when you do a surgery to document improvement in renal function. And fourth is to decide whether you want to keep this kidney behind or you want to do a nephrectomy. So these are the primary indications when you would do a DTPA or EC scan in cases of obstructed system or a suspected obstructed PUJ system. Hello?
Yes, sir.
Yeah.
We are listening. You can
Okay.
ask the
All right.
question.
Sure. What are the definitive signs of obstruction? What all parameters do you look for in a renogram? As a urologist, when you look at the renogram, what all parameters do you look at the quantity or
First,
qualitative? Yeah.
First, sir, this is perfusion and perfusion images, sir. Second one is the O'Reilly curve, and third one is that numerical
Values, the quantitative
values.
parameters. Okay.
Three
And what
values.
denotes obstruction to you on these scans? What are the worrying signs to you? When would you intervene looking at the scan saying that this is what needs intervention?
Sir, first thing is we would like to see the excretory curve of the patient. The excretion, when it even after the so initially and even after the furosemide testing, if the curve is upwards, then it is suggestive that it is not excreting to its normal function. So that
Right.
suggests obstruction. Another thing is the time, the half excretion of the contrast, that is T half. So if T half is more than 20, then it is definitively suggestive of an obstruction. Also, in the delayed film, if there is significant retention of the contrast material inside the dilated PCS, then it is suggestive of an obstruction.
Sure, that's good. And also the differential function, absolute differential function of the kidney less than 40%. The normal range is 44 to 56. Anything less than 40% is definitely a worrisome sign, provided the other kidney has a normal function. If both kidneys have impaired function, then differential function will not be very reliable. One more point is what is NORA? normalized residual activity? So I'll tell you, oftentimes the renographic curve patterns can look as prolonged, or your T half can be prolonged even in a non-obstructed system. For example, if it's a hugely dilated pelvis, or if the baseline cortical function of the kidney itself is low, at that time the kidney will continue to excrete isotopes into the pelvis because of poor cortical function and not because it's an obstructed system. In such cases, based on the curves purely, you will not be able to differentiate if it is an obstructed system or it is a non-obstructed but a sluggishly draining system. So in these cases, you take a ratio of these counts. Basically, you take a post-void image typically at 60 minutes from the injection time, and you take another image at 2 minutes in the earlier dynamic images, and you take a ratio of these. So NORA of less than 0.5 indicates a non-obstructed system. NORA value of more than 1.8 indicates an obstructed system, whereas anything between 0.5 and 1.8 can be considered an indeterminate, and you should follow up these patients. So it's an objective way of assessment whether the system is obstructed or not.
Parag, can I add few things?
Yes, sir. Yes, sir.
Yeah. Basically, Kavan and Anand, this is a common way in which we all answer, and what you have answered is perfectly in sync with what most of the examiners want and the students would answer. My contention is that when you are talking about the drainage, when you are saying the T half is more than 20 minutes, or as Parag mentioned about NORA, I would recommend you use words like poor drainage, partial drainage, or good drainage. Don't use words like obstruction.
Yes.
So when he's saying NORA, this is a very important entity where you are basically calculating the counts which in that particular kidney at 60 minutes and divide it by the counts at 2 minutes. And values less than 0.5 is good drainage, 0.5 to 1.8 is partial, and more than 1.8 is poor drainage. This was a concept which was put forth by a nuclear medicine expert from Belgium, Professor M.E. Pipses. Now, why this becomes important is because, see, the capacity of every pelvis is different. And this is what they describe it as a reservoir effect. This means that unless the pelvis is completely filled, it will not have the stimulus to contract and push that urine from the pelvis into the ureter. Now, there are two aspects which come into play. One is the capacity and compliance of the pelvis. And the second aspect comes is the effect of full bladder and gravity. In a child, especially because this is where most of the renograms, diuretic renograms are done, the bladder gets filled very quickly. The bladder is not emptied. If you look at the classical description of how a well-tempered renogram is to be done, they advocate two things. One is maintain an IV line, and second, maintain a perurethral catheter, which by and large practically nobody does across the world. So once the bladder is full, the drainage is affected. And we also know that gravity does play an important role as far as the drainage from the renal pelvis is concerned. And because NORA takes into consideration all three aspects, that it allows the pelvis to get filled completely, it gives it 1 hour. Secondly, because it's a post-void film, by 1 hour, everybody would be emptying the bladder and it would be a post-void film. And third, the person is moving around or even the child is mobile. So the effect of a full bladder is gone, the role of gravity comes into play, and the reservoir effect is taken out. And hence, NORA is supposed to be a better indicator of drainage of the renal pelvis as compared to the T half values.
Perfect.
Yeah. Okay. So looking how you are going to read this renal scan, Parag, you can ask them question.
Sure.
Can
So
you
can you
provide one
describe?
more film? Let them have a look at both the
Yeah.
films and then they can comment about it.
Yeah.
Yeah. Can you describe the renogram for me?
Yes. Kavan?
Yes, sir. Actually, sir, the curve are not very clearly visible.
Gross
Well,
by the
without-
images, sir, the
yeah.
right kidney is a delayed excretion of the contrast, sir, and the left good excretion. And
What is now you are focusing dominantly on the right kidney. What is the differential renal function of the right kidney?
It is 59.3.
Right. So when we are thinking of an obstruction, here the kidney is having very good function, in fact, better than the other one.
Sir, that can be fallacious due to the dilated renal pelvis because it takes time to fill the pelvis and the excretion, the split function is not assessed correctly.
Parag, your comments on the same because you are assessing differential renal function within 2 minutes.
So basically, when the kidney is, when there is an impending obstruction, the kidney slightly enlarges in size and it actually pulls in more tracer than what a normal kidney function would. So a supranormal functioning kidney along with an obstructed renographic curve is a definitive sign of an impending obstruction, and this definitely needs intervention.
yes,
So when you read a
would-
renogram, you always start from differential function as the first step.
Yes.
Curves are almost the last step of interpreting a renogram. You start with perfusion, you start with an uptake, then you comment about the drainage, then you comment on the differential function values, then you look at the absolute GFR values, the total GFR, and then finally the curves.
Parag, is this a DTP or an EC renogram?
This is the DTPA
yes.
renogram, sir.
Yeah. So probably if you do an EC, yeah, 59.3 would be less, I think.
Largely they go hand in hand, sir.
Yeah.
Yes, go on,
Parag,
please.
there is no
Yes.
mention about the counts at 60 minutes and 2 minutes. If you have any, if you are privy to that information, can you share that here?
I will have to look this up.
Because
But from
I would come to another concept on this particular thing because instead of 1 minute film, these are 1.5 minute films or 30-second films that are
30
coming.
seconds, yes, sir.
And the cortical transit time looks to be quite good on both the sides.
I will have to look up for the image, but based on the images that I've seen on the screen, it does look to have retained tracer on the delayed images, which probably indicates a prolonged NORA.
Yeah, but the bladder is also full by that time.
Yeah, so but no, but when you take a delayed image,
If
the patient,
we looked at NORA at 60 minutes and we are having
yes, sir.
images only till 27 minutes.
No, if you see the other image, so if you could put up the other image, the one with the curves. Yeah.
No, the next one.
No, the curve images with the curves. Yeah. On the right side in the right lower corner, sir, that is
Yes.
the delayed image taken at 60 minutes, and this fair bit of tracer retention seen in that image as well.
Okay.
So the first grayscale image on the right lower corner is the immediate post-void image, and the one on the right side is the delayed image taken at 60 minutes.
Yeah.
So visually, definitely there is tracer retention in this. Of course, I don't recollect the counts taken in. So can you describe the scan again for me? Can you read the scan, please?
So this scan is suggestive of right side split function of 59.3% with a obstructed pattern on the curve with a good cortical transit time, but the GFR normal GFR of 34.4, but the T half is significantly more, and there is significant postward retention in the dilated pelvic ileal system.
It is an obstructed system.
Thank you.
Yeah. Okay, that's all. Queries with us.
Now, a few queries. Do Kavan and Anand agree to the fact that this could be this is a PUJO obstruction and then it would be a congenital one? So
Yes, sir.
why has the function not deteriorated till the age of 48 years?
Sir, one is the fact that the calacial dilatation is significant. So that is one point. And also the system is not completely obstructed. So it keeps
Partial
on.
obstruction.
So the back pressure changes are not that significant to cause the cortical thinning and then the reduction in the function of that kidney.
Yeah. So basically, if at all it is there is an intermittent obstruction, that what we can assume. Now, are we 100% sure that this particular thing is responsible for the occurrence of pain which is there for the last 1 year?
Not sure, sir. It could be.
Yeah, so it could be, it may not be. So if you have to confirm that this is only and only on account of this particular entity, is there something that you can do to be पक्का श्योर कि भैया पेन इसी के कारण है और किसी के कारण नहीं है?
So we can try putting.
We can degestenting we can do, and if the pain disappear, it is secondary to
the placement.
Yeah. Anil, your thoughts?
Indirect evidence.
Pankaj, your thoughts on the same?
Sorry, I was muted. Means, are you really proposing that of digestion? I did not understand what you
No. I just asked ki if one is not sure, looking at this particular thing, that if the pain is actually on account of a renal cause, because this is a condition which is present right since birth. Why should the patient have pain in the last 1 year only? And if we have this particular thing, is there something we can do to be 100% sure? So they answered that a DJ can be put, and if that has relieved the pain, you can be pretty sure that this is the reason for the pain.
So in situations where there is a confusion, that's one step that can be taken.
Dr. Parag, you want
Otherwise,
to
it's preferable to avoid putting in a digestant because if when you are operating, presence of stent will cause inflammation to the ureteric wall and the renal pelvis, and your surgery will become a bit awkward. Right? Even if the patient has associated infection which needs to be drained.
Yeah.
Yeah, Neil, go ahead.
Yeah.
Okay.
Can I? Sorry, I was my mobile get some problem. Now I join. So most probably the function is not deteriorated. One of the reason I can say that it is most of the pelvis is extrarenal and the bunt is taken by the pelvis. If this pelvis would have been intrarenal, then it would have given little more, and it is definitely intermittent obstruction. And as CT scan we have, which is suggestive of some impression of crossing vessels, as well as these renal scan findings. Altogether, if we say that it can explain the intermittent pain, which is I can say hallmark of the crossing vessels, which is responsible for the intermittent ureteropelvic junction obstruction.
True.
And we can definitely go ahead with the intervention if the patient is symptomatic.
Yes.
So
and I
before
agree
we go
with the
ahead,
Pankaj for not to put a stent because it can cause several problems. Right.
Agreed to whatever Anil has said. It was just a question that if there is a dilemma in some situations,
Yes, agree.
That is where you put in a DJ.
Yes, agree.
Yeah. So before we go ahead, can I ask Parag if he wants to ask any other question? Otherwise, he can, if we are going towards the surgery, he can leave. So Parag, you want to ask any extra question?
No, sir. I think we've covered most of the points here. as far as
Yeah,
PUJ obstruction
of
is
course, we will
concerned.
be doing the full renogram with you in
Yes, sir.
one of the later classes.
One question I want to ask him and get some clarification, because this
Yes,
was the
sir.
talk which was given to me in
Sure.
recently held pediatric urology second annual meeting Jaipur last Sunday only.
Yes, sir.
My talk was EC versus DTPA in a
Mhm.
suspected case of UPGO specific like that.
Right, sir.
And
Right.
you and responders have discussed most of the things. Now here probably this is a DTPA. What I
Yes, sir.
assume that if this is EC, then the
Mhm.
images would have been much sharper. And
Definitely, sir.
problem with the background activities and sometime over estimation of function or some misjudgment in the function, this
Yes.
can be avoided
Yes,
in
yes.
this kind of. Even
Definitely,
patient is of
EC
this.
images are cosmetically better, but the information obtained from an EC as well as a DTPA in an optimally functioning renal system is similar, sir. It does not impact any interpretation as far as function and drainage is concerned. If the kidney function is normal, if the kidney
Right.
function is suboptimal, definitely EC is the preferred modality.
Right. And second thing, sir, not in this patient, but suppose
Ah,
it's a smaller child. How far
yes, sir.
you people rely on the diuretic curve rather than the diuretic curve? You much more focus on the cortical transit time, or we don't have an
Yes, sir.
objective cortical transit time, and we just have a visual impression that there is a
Mm.
delay in the cortical transit time, which is I
Theoretically,
think
yes,
this is
we
the typical question of Gyanendra, but as he has not still, I think, raised this. Yeah.
Yes, sir. In pediatric patients, of course, cortical transit time is very important. But practically, we go more by visual interpretation. And in cases where we have doubts, we then squeeze in the NORA more than the cortical transit time value per se. NORA
Perfect.
is
Perfect.
more dependable than the cortical transit time
Okay.
value as
Got it.
such.
Got it. Got it. Thank you.
Now,
Thank you, sir.
one question to all three of you.
Yes, sir.
Whenever we are in doubt, now here, how much Lasix we are giving and in the PU junction, and what is the ideal time to give, number one, and number
Yes.
two, suppose if we are in dilemma,
Mhm.
if we give large amount of Lasix, that is 40
Mm.
milligram or little
Mm.
more,
Ah.
will it definitely show the obstruction?
We usually give, now there have been multiple studies which have tried F minus 15, F plus 0, F plus 10 protocols. But there was one large meta-analysis published of 17 years pooled data across multiple studies, and they concluded that F plus 0 works the best irrespective of the extent of hydronephrosis. So as a result, consequently, in the today, most organizations will do an F plus 0 renogram by default. The only condition where potentially F minus 15 will be considered is where you have a hugely dilated system, like a grossly dilated cervical system, where you want maximum diuresis right from the outset. Otherwise, for all other conditions, F plus 0 protocol is the default protocol to go ahead with. Lasix is typically 1 mg per kg, but for most adults, we give 40 mg as a standard dose, and pediatric patients, we usually end up giving 20 mg as a standard dose.
Parag, if I may add, this
Yes,
particular
sir.
thing became a standardized protocol in 2019 when the European Society, INAM, and Society of Nuclear Medicine from
Yes,
US, they had two different protocols, and then they
right,
finally
sir.
came up with a consensus
Yes,
in 2019 where
yes,
they
yes,
endorsed the F0.
yes, sir.
And here I can also add that from India, Dr. Ramesh Babu had published a study where he had done a comparison of F0 and F minus 15, and he found that F0 works equally, or rather
Correct, sir.
is the preferred choice.
Yes,
So
sir.
across Europe, everybody follows F0 pattern.
Yes, sir. In India as well.
Yes.
Everybody does F0. In case anybody is asking for an F plus 10 protocol, which is very rare, in case anybody is asking, just be sure that you ask that the renogram continues for at least 20 minutes after the F plus 10. That is a
Yes.
30-minute renogram. So that the action of Lasix at least continues for 20 minutes.
So, Nanendra, another question is that instead of 40, if we give little extra fluid and we give little more Lasix, are there chances that it will show proper obstruction?
Sir, the optimal dose is 40 for an adult also. And in a child also, it's 0.5 to 1. Most of the people give 1 milligram per kg. So in a well-hydrated patient, so that is the most important thing. The person should be well-hydrated. Otherwise, the effect of furosemide is definitely subdued. So well-hydrated patient, 1 milligram per kg, maximum dose of 40 milligram is good enough to give us the information that we need to come to a conclusion. Now, sir, why this particular thing comes about is because traditionally we all are fixated with this concept of looking at T-half and the drainage curves. According to me, and this is strictly my opinion, which I vehemently and very strongly endorse, but I would advise all the residents that in your exam, you keep on answering T-half more than 20 minutes is a poor drainage. I feel both this drainage curve as well as T-half values are not of much use, especially in children or even in adults, because we are not taking into consideration three important things: the capacity and compliance of the pelvis, the effect of gravity, and the effect of full bladder. And there are n number of studies which have proved this beyond doubt. Better parameters to look at and to define obstruction are differential renal function, cortical transit time, and NORA. In fact, there is a very recent study, when I say recent, it's about 1.5 to 2 years old, which have looked at into this T-half defining obstruction. And what most of the nuclear medicine people do is they will see it over, say, 24 minutes, 30 minutes, and that's the end of it. They looked it for more than 1.5 hours, and they found that if the T-half is more than 75 minutes, then definitely this system is obstructed. If it is less than 5 minutes, then it is definitely non-obstructed, and anything between 5 to 75 minutes is equivocal. Now, practically speaking, nobody would be looking at for 5 to 75 minutes in a young child. It's impractical. So if we look at the practical implications, the simple funda, let us look into what is meant by a PUJ obstruction. When we say obstruction, how do we define obstruction? And there is no better definition of obstruction than what was put up by Stephen Koff in 1998, who said that obstruction is any impediment to the drainage of urine which results in deterioration of renal function. Now, what we are worried of is we don't want to wait till the renal function deteriorates and then we want to intervene. So what we are looking at is indirect evidences which suggest that yes, this drainage is poor and it can indirectly result in deterioration of renal function. So when we look at drainage of the renal pelvis, according to me, NORA is the best parameter because it takes into consideration everything which can by and large falsify the results. Secondly, if the drainage is poor, it will result in back pressure effects. And as we all know that whenever there is back pressure effects, the kidney concentrating and excreting ability is affected. Now, when we talk of the concentrating ability or the ability to pick up a particular contrast, this gives us the differential renal function. And we talk of the excreting ability of the kidney, we look at the parenchymal transit or rather the cortical transit time. That is the time which is taken by the tracer to come from the renal parenchyma into the pelvic ileal system, which by and large, if you look at the visual method, is taken as up to 3 minutes is taken as normal and anything above 3 minutes is taken as abnormal. But for the sake of students, I would say in your exam, it is till date at this particular point of time, it is better if you say ki, okay, T-half more than 20 minutes, it suggests poor drainage, the curve is upgoing, and we think ki it is likely to be a poor drainage which can affect the function of the kidney.
I'll just add one point to this, sir. If
Yeah.
you look at the genesis of the curves, why they emphasize so much on the curve pattern is the initial renograms that were done when renograms were done in the historic era, they had gamma probes. They didn't have the imaging system. They were just counting probes kept on the back, and patients' counts were calculated on the kidney by non-imaging techniques. And that's why they did not have the images to characterize how the drainage is, how the pelvis is. Sonography also wasn't as really available then. And that's why the parameter of T-half was so important back in those days. But in the today, even we as nuclear medicine physicians do not rely on the values of T-half as such. As you rightly said, the delayed images or the NORA is more important, and the cortical transit. These two parameters are what we emphasize on rather than the top patterns.
See, Parag, what you say is very right. See, what happens is that if you look at the ideal way in which a renogram is to be done, then there is an IV line and there is a catheter. Nobody puts in a catheter, and when you give
Yes, sir.
furosemide, the bladder fills up, it affects the drainage.
Yes, sir.
Now, all this concept of a well-tempered renogram started from one particular paper, I think, which was published in 1982. And these were patients who were not young infants or young children. They were all adolescents or adults, where they were
Yes.
pakka proved obstructed cases who were majority of them were symptomatic. And once there the value of T-half got established at 20 minutes, this went on and on and on. So that has become like sacrosanct. Ki T-half more than 20, everybody says that it's an obstructed system. But I think it is just a matter of time. In few years, you will have a lot of papers as well as textbook mentioning that T-half values will not be taken on face value. It can't be relied upon completely.
Agree, sir.
Okay, fine. So Parag and Sharma ji, if you are
Yeah.
concluding about this renogram, then we go ahead.
Sure, sir.
Yes, sir. Yes, sir.
Okay, okay, Parag, thank you
I'll
very
take
much.
your leave, sir. Welcome, sir.
Okay, thank you very much.
All
Thank
right.
you.
Thank you.
Okay, fine. So now next what? Kavan, Anand, I will ask first Anand. Anand, now what you want to do?
Sir, as the patient is symptomatic, though the spleen function is good, sir, and draining pattern shows obstructive curve, I will give the patient the option of either surgical management, or the patient is symptomatic, I will give the surgical management, sir, in the form of laparoscopic or open pyeloplasty.
Okay. So my question, as earlier even Sharma had asked, Ananda, that what about degescenting? Now I'll tell you very frankly, whenever I'm in doubt, now this is if it is showing definite obstruction is a different thing. But sometimes it's like a partially obstructed system. And still patient has got a pain. And then in that case, it is advisable directly to go for, and it is a parenchyma is a good thickness. And then function is also equally good. Directly go for a surgery, or you want to put a digestion.
Sir, if at all we are planning for surgery, then putting a digestant will cause fibrous inflammation of the system, sir. But if the patient doesn't want surgery or he wants some conservative approach, then I will put digestant on the right side.
So come on, what is your take on this? Do you think that digestant you should put or directly go for a surgery?
Sir,
Sir, if
but
we
and one more thing is it is a extensive compression, sir. Digestant doesn't help, sir, in extensive compression.
I didn't get you. What you are saying?
Sir, the PUJO is second, sir. That aberrant vessel, sir. In this setting, digestion won't help, sir. It's not that much significant because the obstruction will be constant.
No, Anand, I will not agree with this.
Yeah.
An accessory vessel always causes an intermittent PUJ. Now, if you look carefully at number of images or figures which are there in most of your standard textbook, what does it indicate? That whenever there is, see, the accessory vessel is present right from birth. It is over a period of time that the intermittent PUJ obstruction tends to occur, which results in a dilated pelvis, which is compliant. So when it gets filled with fluid or urine, it sags down and there is a kink which tends to occur, which causes intermittent. And on account of some change in posture or something, when this kink gets corrected, they suddenly pass large amount of urine and the pain is relieved. This is a typical details crisis which is seen in intermittent PUJ obstruction. So I wouldn't agree with the fact that an accessory vessel causes a persistent external compression. What you are talking may be true in cases where there is retroperitoneal fibrosis or malignancy, but not an accessory vessel.
Yeah.
Okay.
So, Anand, I will put you one scenario that I am in doubt, and the function is not equal on both the sides. Rhinogram is not very conclusive of obstruction. And then if I decide to put a stent, now if I put a stent, then two things will happen. Either the pain goes away or pain continues. So now in either case, now what will be your interpretation and what you will do next?
Sir, if pain goes away, then it is a definitive that the pain is secondary to this PUJ obstruction, and if it doesn't, then it may be secondary to some other cause. And
So now if you put the stent, pain has gone away. Now what you will do?
I just, sir, I will counsel the patient that after putting DJ, the pain disappears. The pain is secondary to that PUJ obstruction. If she is subjected to pyeloplasty, she will definitely benefit, sir. And the other option is, sir, I will keep her on a repeated follow-up of means every 3 monthly DTP functions, DTPA rhinogram, sir. And if the function deteriorate or the pain aggravate, then there is a definitive indication of surgeries.
So you mean that after putting a DJ stent, if the pain goes away, after few days, like after 1.5 months or maybe 3 weeks, you will remove the DJ stent. And if the patient is willing, then it's okay. Now, after that, the pain doesn't occur, you will do the follow-up. And if the pain occurs, then you will operate. That is what you're...
Yes, sir.
Come on, do you agree with him?
Sir, after putting the digestant, if pain goes away, then patient is straightforward indication for surgical correction of the PUJO. So I would not like to give the option of keeping it under observation after DJ removal. And we will explain the patient regarding the surgical exploration. If patient doesn't want, then it is a different thing.
Okay. And if the pain doesn't go away, then?
Sir, then at least for 1 month, we would like to watch with the digestant. Even if after 1 month the patient is symptomatic, then we might consider evaluating the other causes of such pain.
And then what you will do? You will remove the digestant.
Yes, sir.
And then you'll forget about that kidney.
No, sir, we would like to keep the patient under close observation. And if other evaluation does not give any other significant cause of pain, then we might repeat the evaluation at 6 months and then proceed.
Fine. So let us now ask Dr. Takwani. Takwani ji, what normally you do in such cases when patient has got a pain, but then DTPA renal scan is showing that partial obstruction is there. It's not very conclusive, but this type of picture is there. So in that case, is it advisable to do DJ stenting or just directly go for a surgery?
No, it is not like that. It is not advisable because you can definitely judge the outcome that if the DJ serves the release the pain and there is no pain, for example, for 2 to 3 months, the time you are keeping the stent, it gives some idea that there is a obstruction which is, for example, here is not going to be definitely relieved by the only stenting. Once you remove the stent, again there will be intermittent pain, and there is some chances now there can be associated infection. So we have to go ahead with the surgery. But routinely in my practice, if I'm not convinced with the whatever available investigations are there, which is possible, then I keep patients observing, not treating pain with the stent. If I feel no, this is intermittent pain, and the picture like see with what you have shown today, a CT scan or a confirmed sonography, which is suggestive of something crossing at the UPJ, which gives the here it gives the impression there. And sometimes somebody have done detailed CT scan and angiographic this arteriogram plate, and there is a definite crossing vessels, and there is this kind of intermittent pain, though the split function is very much in the range, means it's preserved. I will assume, as I said, that it is because of mainly external pelvis which has taken the burn. But as the patient is symptomatic, we have a justification in operating this patient rather than just putting the stent. But if there is some doubt in some cases, we have only two options. Either we go on continue observing, or we can take a one more thing for a clue, as a clue that whether the pain is getting relieved with the temporary double J stenting, and if it is, then there is a much more stronger reason to go ahead and operate.
Okay. So Sharma
But
ji, now in
one thing where, for example, in VUJ obstruction, many center in the Western countries, specifically in the UK and few countries in the Europe, they just treat with the stenting sometimes, and they even treat sometimes with the dilatation and the stenting. And they says that good number of patients are getting cured, which at least I have not observed for VUJ also in my practice, and not observed at all in the PUJ cases. If PUJ cases, suspected PUJ cases having some relief because of stent, then I believe there is a strong reason to go ahead and to operate once we almost sure that these putting the DJ stent has resolved the dilatation and given some relief in the dilatation as well as in the pain.
fine.
Agreed.
So Sharma ji, what is your take? Means how the student should answer, whether because some examiner might be doing the DJ stenting.
Sir, I see this question of DJ stenting would come only in adults.
Yes, only in adults.
Only in adults, not in children. So,
Correct.
in adults, yes, if this is this type of case has come and then there is a dilemma, then one can answer ki, okay, if one is not sure, you can put a DJ. But in a child, if you are not sure that this is pakka obstruction, wait, follow up with sonography, and if needed, a repeat renogram. That's it.
I think you made it very, very clear, both of you, how to go about. So in exam, I think the students will be able to answer properly, looking at the case. Can we just go ahead with the two different scenarios very fast? Sharma?
Yes, sir.
Yeah, we can go a little faster.
Yes, sir. We
Two
go
cases,
ahead. Yeah.
two different scenarios. So just okay, fine.
He was a
Vijay,
4-year-old.
fast.
Yeah, present with the complaint of pain over right flank on and off since 4 months. So pain was dull aching as told by her mother. The rest all clinical histories were normal, no any congenital anomalies external.
One small interruption. Honestly, is the history correct or it has been made up?
Made up. I think because
I will tell you.
in nature,
I will tell you why.
Can't say.
A 4-year-old female will never give a classical history of pain radiating from a flank to the front. This is very unusual.
Only patient came with a pain on right side.
Yeah, that's it. And very often there is pain in the abdomen. That's it.
Yes.
Yeah.
So rest all the histories were normal, sir. External genitals were also normal. Blood reports were normal.
Yeah.
So patient came from outside, was referred from outside and already presented with this reports.
Was ultrasound first?
Sir, actually, she had came with the CT report, sir. Her relative was some local clinician, so they already did a CT KUs.
Oh my God. See, something which I think Anil has been trying to tell with over the top with the loudest voice that he can have, that please don't get CTs and CT urographies in children for PUJ obstruction. The ultrasound gives you all the anatomical details. A good ultrasound by a person who is well versed in doing sonography in children, and the functional information can be obtained with a renogram. Besides the biochemistry, these are the only two investigations, and very rarely a VCU gene which is needed in children who are being evaluated for PUJ obstruction. In your practice, even in exams, we would suggest, and myself and Anil would strongly recommend, don't ask for CT urography. You are unnecessarily subjecting a child to very high levels of radiation. Okay, anyway,
I
the
think
CT has
you made
been
your
done.
point
We go
very
ahead.
clear. You made, because the last time also in last all the 4 seasons when we have discussed, we have told the same thing,
Yeah.
that in children, sonography, even last time when you came, you had done the same thing.
Yeah.
Yeah,
Okay.
fine. Go ahead.
Go
So
ahead.
let us, yeah. Anand, just
Yes,
go
sir.
through this city and let us know what is your finding.
This is the CTKU showing liver and other ulcers are normal, sir. The right kidney, sir, is a grossly dilated pelvis, sir, which mm, left kidney, sir, appear mild fullness of the left kidney, sir, grossly normal, sir. Right kidney is dilated. Possibility PUJ obstructions.
Okay. So Kaman, now you want to do comment anything more or you want to do anything else?
No, sir, we can see the nephromegaly on the right side with pancreatic dilatation with a grossly dilated extrarenal pelvis. We cannot delineate any ureter is not seen in the plates, and left kidney is showing just sinus dilatation, the splitting of the calyces, but no significant dilatation. So, sir, in this case, we would like to go ahead with the functional scan, sir.
Why want to do functional scan? Why not to operate directly? Your diagnosis is there.
Sir, this is a plain CT. We
Don't you
don't know.
think that right kidney is affected, the parenchyma is affected?
Yes,
Sir,
sir. Just same.
parenchyma looks thin over the upper pole, sir. And in case of pancreatic dilatation with such a hugely dilated renal pelvis and nephromegaly, the function will be affected. So we have to quantify the function on that side. So, and also we have to prove the obstruction because it's a plain film. There is no comment on the excretion of that kidney or function or obstruction. So we have to go ahead with the radionucleotide scan, sir.
See,
Good.
very good. But remember, when exam, Dr. Parag, he told you the 4 reasons why you want to do DTPA or EC renogram in PU junction obstruction. Remember always those 4 points.
Yes, sir.
Okay, so even if the examiner says, okay, this is dilated, it is obstructed, why you don't want to go ahead? All the 4 causes reasons you have to give, and then say, okay, this is the reason I want to do DTPA renal scan.
Yes.
Very good. Okay, fine, sure. So even if CTQB is saying
There is right
that
pelvic
is,
junction obstruction.
yeah, okay, go ahead. Show them DTPA renal scan. Now here it is saying cortical function and delayed non-obstructed excretion.
Left side.
And the right side also.
Right side also no.
Delayed.
Sir, can we see the first plate?
Yeah, sure.
So, sir, the reason they have mentioned it being a non-obstructed system is that in delayed plate, they have seen that more than 50% of the pelvis is excreting the agent. But, sir, we can see that there is significant retention of the agent in the
agent in the
and
right
all
kidney.
these are also showing the presence of agent. So, I mean, this reporting
Due to
but clinically it seems like a obstructed system only. So we would like to go ahead with the surgical treatment, sir.
Okay.
one more thing,
Sakwani
sir,
ji.
I would like to add is the right kidney is grossly dilated, sir. The function on this right kidney may be fallacious high, sir, because of gross hydronephrosis. If you want to if you want to calculate the exact function, sir, either we means after putting a DJ stent or something for 4 to 6 weeks and then reassess the function, that will give us a fair idea of exact right sleep function in this GFR.
Okay. So, Dr. Sakwani, can you just ask them a question about fetal ultrasonography and so that we can complete the examination? What are the findings they should look for during neonatal ultrasonography? GR, you can also comment on that.
I think he has left, sir. I don't see him on the chat.
Yeah. GR can tell us.
Hello.
Yeah. So GR,
Yeah. Sir,
because now we are discussing the child, so what are the things they should ask mother during history as well as what are the important
sir,
findings
most
and
of the
sonography
times
they
what
should ask
happens
for?
is that the mother is coming with the child. If there are three scenarios that commonly happen. One, that the parents know prenatally that there is hydronephrosis. So that time we need to be, they come to us what needs to be done. So when should you do the first ultrasound? Now it should not be done within the first 48 hours because of the relative degree of dehydration that a neonate has. And the assessment of the hydronephrosis is not accurate in such a scenario. The only exceptions to this particular dogma is when you are suspecting PU valves, there is bilateral PUJO obstruction, or there is a solitary kidney with hydronephrosis, especially if the AP diameter is more than 15 millimeter in the third trimester scan. So let us assume that it's a unilateral hydronephrosis, which is PUJ obstruction like picture, PUJ like obstruction seen on ultrasound. And the baby comes on the 4th or 5th day and an ultrasound is done. We look for both the kidneys, the size of the kidney, the presence or absence of hydronephrosis, the degree of dilatation of the renal pelvis, the calyceal dilatation, parenchymal thickness, the echogenicity of the renal parenchyma, presence or absence of dilatation of the ureter or any abnormality in the lower end of the ureter. Now here, there used to be a confusion. I don't think that confusion exists anymore is how do you classify that hydronephrosis? So we usually objectively state the anteroposterior diameter of the renal pelvis, which is measured at the level of the renal hilum, preferably within the confines of the renal parenchyma, in a well-hydrated child with the bladder empty. And at the same time, as per the multidisciplinary approach on the basis committee report, on the basis of which the urinary tract dilatation or the UTD classification has been put up, you also need to specify that the AP diameter was measured in which position, whether it was a supine, that is slightly lateral, or whether it was in a prone position. Now, this is because it was our study of which Pankaj was also part, that when the AP diameter decreases in prone position, these kidneys are usually draining well and they don't end up requiring surgery. Otherwise, if they increase in AP diameter by more than 10% in prone position, then the chances that these kidneys would require intervention are very high. So if somebody asks you in exam what you will ask for, you will ask for everything. Size of the kidney, echogenicity of the kidney, AP diameter of the renal pelvis, parenchymal thickness, dilatation of the calyces, the absence or presence of hydroureter, what is the status of the lower end of the ureter, the bladder, as well as the whether any dilated urethra is seen or not. Now, immediate postnatally, there are three things that can happen. One, that prenatally there was hydronephrosis and postnatally there is no hydronephrosis which is seen. Now, either the hydronephrosis has subsided or it is equally possible that it may reappear later. So in such a scenario, you will always ask for a repeat ultrasound at 4 weeks and 12 weeks. Second scenario is that there is dilatation of the pelvic calyceal system, and then you look at how much is the dilatation. Now, as per the book, they are mentioning 15 millimeter, 30 and more than that. I usually don't follow it. I look at whether the AP diameter is the same in supine and prone. If it is increasing, I would label it as a poorly draining system. If it is decreasing by more than 10%, it's a good drainage, and anything which is in between is equivocal. My policy is anything where the parenchymal thinning has occurred and you feel it's a poorly draining system, or the AP diameter is more than 30 mm, or it has increased in by more than 10% in prone position, I would start the child on chemoprophylaxis. That is antibiotic prophylaxis, either using amoxicillin or cephalexin, and get a repeat renogram at 1 month, that is at 4 to 6 weeks of age. Here again, if the ultrasound is showing deterioration and it is showing a sort of a poor drainage pattern, by which I mean that the AP diameter is increasing in prone position, then I would advise a renogram at 4 to 6 weeks. If it is good drainage or an equivocal pattern, I would wait and again repeat a sonography at 3 months. And maybe if that time significant hydronephrosis is present, I would ask for a renogram at that point, which would serve as a baseline renogram for all my future follow-up. The only exception to this rule is that if the hydronephrosis is decreasing, the parenchymal thickness is improving, and there is no increase in the renal size. By means, when I say increase in the renal size, I say the dilatation of the pelvic calyceal system causing nephromegaly is absent, then I would still continue to follow up that child using sonography and advise a renogram only and only if there is deterioration seen on sonography. Anything in specific, sir, or anybody wanted to know, I would answer that, sir.
Sir,
Yeah,
postnatally,
no.
you would re-stratify the patients with the UTD classification, or you would prefer SFU gradings?
I never follow the SFU grading. And for that matter, I don't follow the UTD classification also. I look at the AP diameter in supine and prone. And if it is showing good drainage, that is more than 10% reduction of the AP diameter in prone position, I would say it's a good drainage. Increase by more than 10%, it's a poor drainage. Anything in between is equivocal.
Okay.
And talking about the two grading systems, Gyanendra, means UTD is more, say, the long-term results when you grade by either are similar.
Sir, there is one study which says that the inter and intra observer correlation is better when you look at AP diameter as compared to the Society of Fetal SFU grading. And that is why
Oh.
the Onen and the modified Onen classification came, because there was some confusion as far as the SFU grading was concerned.
No.
So,
So in a prospective study of more than 100 kids, where both the grading systems were used, they found that say P3 as well as this thing in long run, the need of surgery was similar with both the grading systems.
Yes. But then this 3, 4, there is some confusion most of the times.
So JRS, I will ask Anand and Kavan at least to talk about both the system, so that the other students, they also become aware what is this system and why it is so important. Grading
the
system.
See, I will give a background to it, sir. What happened is that 8 big institutes where good amount of pediatric urology work was done, which included pediatric radiologist, pediatric urologist, and pediatric surgeons. And they all came together and they evaluated all the literature which was put up. And I think in 2014 or 16, they came up with that statement which was coming by the name of multidisciplinary committee report on how do you classify it. And then they classified it as low, intermediate, and high risk. And this was subsequently published by Guyan along with number of other authors. And that has now become standardized as a UTD classification, where one of the most important aspects that has come is stop using the term hydronephrosis. Because traditionally, most of us believe that hydronephrosis is aseptic dilatation of the pelvic calyceal system on account of partial or complete obstruction to the drainage of urine. While the studies on prenatally detected hydronephrosis proved that hydronephrosis is just aseptic dilatation of the pelvic calyceal system, it may or may not be associated with obstruction. So hence they advocated the use of the term urinary tract dilatation, which encompasses everything. It could be dilatation, anything from top to bottom. And hence this UTD classification came into being, and I think it was so described in 2019. The residents can correct me because it's been a long time since I've read that. Anand and Kavan, you can add to it.
Yes, sir. So the Society of Fetal Urology classification is for the neonatal and infantile cases of hydronephrosis, which was detected antenatally, and they have divided it into 4 grades. Basically, grade 0 is no dilatation, while the grade 1 is dilatation of just the pelvis, or as they say, sinusal dilatation. The grade 2 is the dilatation of the major calyces. The grade 3 is dilatation of minor calyces, but the parenchymal thickness is normal, while the grade 4 is associated with the pancalacid dilatation and parenchymal thinning. And the UTD classification is divided into the antenatal as well as the postnatal classification of the hydronephrosis. And they have seen mainly 2 things. One is the anteroposterior diameter of the pelvis, and second thing is the presence of some high risk features that they have defined on the ultrasound, which includes the central or peripheral dilatation, the thickness of the parenchyma, the echogenicity, as well as the presence of ureteral dilatation, the appearance of the bladder, and presence of oligohydramnios in the prenatal setup. And then they risk stratify the patients into low risk, moderate risk, and high risk, which is A1, A2, and A. And then re-stratify the patient postnatally after the post 48-hour ultrasound. And then the follow-up protocol is made such that the low-risk patients are the sonography is repeated within the 6 months, while in the P2 risk it is 1 to 3 months, and in the high risk it is within 1 month.
Yeah. So, but what is low, intermediate, and high risk?
So, sir, low risk is in antenatal period between the 16 to 27
second and third trimester, sir. Second and third trimester. For second trimester, and transfer diameter is for mild is less than 7, moderate is 7 to 10, and high risk is more than 10 mm. For third trimester, it is up to 9 mm, 9 to 15 mm, and more than 15 mm. Mild, moderate, severe.
And post after delivery?
Sir, it is if 10 to 15 AP diameter and no high risk features, then it is low risk. If it is more than or equal to 15 millimeter with absent high risk features, then it is intermediate P2. And if with more than 15 diameter, if there are high risk features, then it is P3.
Okay. So what is the importance of this?
So basically, sir, it is for the assessment that because of that theory that around 40% of the postnatal hydronephrosis resolves over the time. And among the persistent hydronephrosis also, the patient undergoing the surgical intervention in the follow-up period is different between these three groups. So in the low risk group, the P1 group, it is the chance is 1%, while in the P2 it is around 5 to 10%, and in the P3 it is around 40 to 50%. So to risk stratify the patient, we prevent the surgical intervention in the patients who doesn't really require them.
Okay. So that is why high risk you will definitely like to operate, and in low risk you will might like to conserve. Correct?
Yes,
Yes,
sir.
Sir, I would rephrase it by saying low risk can be followed up with sonography, high risk require renogram.
Yes, sir.
Okay, sir.
Okay. Fine. I think we have discussed quite a lot. Anything is left?
Sir, later
Yeah.
on we can discuss the operative part.
Yeah.
Sometime next, maybe some other class we can take.
So next class we
Yeah.
take the operative as well as the third case. Is it
Yeah.
okay?
Yes.
Yes, sir.
Yes, sir.
Okay. Okay. Fine. I think today's thank you very much to you. Really, it was very, excellent discussion you have made, along with even Takwani and our nuclear medicine doctor. So I am very happy, and we'll continue it next Tuesday.
Yeah, sir. The last one sentence that I would like to say is, sir, thank you for calling me. And I would also ask all the residents that when they will be in practice, look at the renogram center who are doing it in a proper way. I know number of centers where actually the function would be hardly 20-25%, but their renogram will say 45%, 43%. And then you are in a dilemma because renogram is not gospel truth. There is a man behind that machine who is governing a lot of things. And very often if the technicians make a mistake, the values can be very erroneous, very erroneous. In a this particular case that we are being shown, when you look at the CT films, you expect the function to be less than 40%, and here it is, which is 50%. And it can happen on account of an erroneous way in which a nuclear diuretic renogram is done. So choose the person with whom you get the sonography done and where you get your renograms done very properly and meticulously.
So, GR, I can request you that I know you have got a lots of good collection of ultrasonography. So next time when we are discussing, if you can just show different ultrasonography and explain them what to look into, that will help them a lot.
Yeah.
Correct? So we
Okay,
will
sir.
have that also, and I will request one of the students to discuss about the different surgery,
Yeah.
little theoretical,
We'll, sir,
along
take
with the case
that as well as
presentation.
the follow-up post-pyeloplasty.
Yeah. Okay.
Yes,
Fine.
sir.
So we will discuss out how to go about for the next.
Sure, sir.
Yeah.
Thank you,
So
sir.
thank you
Excellent
very much.
insights.
Thank you, sir.
Yeah.
Sir.
So that was very good on Parag, on Takwani and GR. So of course, Maheshwari's input is always there to help us. Okay. Good night.
Good night, sir.
Good night.
Good night, sir.
Good night, everybody.
Good night.